So why don't we wait like 1 minute, just as I still see people joining in. All right, so shall we get started? All right, well, welcome everybody. I'm guessing some more people will filter in. My name is Nick Papageorge. I'll be moderating this webinar. We've titled it Modeling COVID from the Society to the Individual, Weighing the Trade-offs. And we are absolutely delighted to host Michèle Tertilt, a professor of economics at the University of Mannheim. She's written extensively on economic development with some particular focus on gender inequality and female empowerment. She's also written on the HIV/AIDS epidemic in Africa. And today she's going to present work linking human behavior during COVID to aggregate economic output and the course of the pandemic. We're also thrilled to have Melissa Marx with us as a discussant. Melissa is an assistant professor in the Department of International Health here at Hopkins in the Bloomberg School of Public Health. She's currently leading the Bloomberg School's support of the Baltimore City Health Department's response to the COVID-19 pandemic. Her pre-COVID non-outbreak work includes evaluating global maternal child health and HIV, TB, malaria programs. So there's a lot of, it seems like there are some overlapping interests here. I look forward to the back and forth. A quick set of details before Michèle begins. Attendees are to stay muted. If you have questions, please use the chat function or the Q&A function. Either one is fine. One of the co-authors of the paper will be able to answer some questions that way. But I'll also be sort of pulling some questions for the end. When we have some discussion. There will be a 35-minute presentation by Michèle, a 5 to 10-minute discussion from Melissa, and then the rest of the time will be for open discussion, moderated discussion, and then maybe I'll have a couple of questions of my own. So why don't we go ahead and get started with Michèle's presentation?
Okay, well, thank you very much for having me. So let me share my screen here. Let's see. Okay. Yes, I'm very excited. Can you hear me? Yes. Okay. So I'm very excited to be talking here in this sort of interdisciplinary forum. So I think we can really learn a lot from each other, combining economics and epidemiology. So I'm looking forward to a good discussion. So this is joint work with Louise Brotherhood, who's here today, and also Philip Kircher and Cesar Santos. And Well, let me start with a word of caution. This is work in progress. I think we are already pretty, well polished, but there will be a new version soon. So we are adding a few other things. Let me start with an introduction. So as everyone knows, the global COVID-19 is clearly a global pandemic. I think pretty much everyone in this world is facing this right now, this issue. A few things that really are, striking is that age matters. And that's what I want to talk about today. So age matters here on multiple dimensions. The death rates are very different for the old. But also behavior seems to, differ by ages. It's related, obviously. I want to also talk about externalities and policy by age. Another thing that's really important, testing sort of seems to work. So I'm going to be talking about testing today and what that means in a model. And the focus is going to be on behavioral change. And I think that's what economists can maybe, contribute here, is sort of trying to assess to what extent people are voluntarily socially distancing themselves, even without a policy, and then what can policy add on top of that, or maybe in some circumstances not add. So I want to have that's the point of this paper, having a discussion on those issues. So let me, 35 minutes, not very long. We have lots of stuff, so let me start with a summary of the main insights of what we think the main insights are. So it's going to be a model of behavior. I wrote simple, it's not so simple actually. A model of behavior, people making choices. Incomplete information about the infection status is key. So people just, a lot of people don't know. And age being important. When I say age, really, we're just going to have two age groups, old and young. We could think about adding more, but that's what we do right now. In terms of insights, the benchmark model, the old are actually protecting or shielding themselves a lot voluntarily, and that by itself already cutting, and the young too, less so than the old, but they're also protecting themselves to some extent, and that by itself already cuts death by a half. So that's a huge effect. GDP has also declined some just because people voluntarily, working less, spending less time outside, but that's a moderate GDP decline of 3% here over a whole year though. Secondly, there is a positive externality in the benchmark. What I mean with that, this is on top. So typically infectious disease models, we have these negative externalities because people only protect themselves for their own benefit, but don't take into account that, if they're behaving less riskily, they're also, protecting others in some sense. So here on top of that, there is this sort of hidden positive externality that it really, the dynamic externality, because eventually, we're going to reach, or in some scenarios, we're going to reach a level of herd immunity. And if we reach that through the young, it's much better than reaching it through the old. So it can actually be better in some, and I want to talk about that if the young are sort of engaging in kind of risky behavior. And I want to talk about this positive externality. In terms of policy insights, the general shelter-at-home policies really only work in the short run. So if we think there's going to be something, a magic soon in half a year or so, some new medicine or something, then they really work. But beyond that, they're not really saving many lives in the long run. Especially just sheltering the young can actually backfire and lead to more death. Is what we find in this model. Granted, there's a lot of assumptions. I'm not going and telling the German government right now, but at least in this model, there can be more death in the long run. Sheltering the old, so sort of kind of locking up old people in their nursing home even more than they want to. They're already doing this a lot, but locking them up even more saves lives, but in terms of welfare, it's actually costly. So it saves lives, but they don't like it. And the reason is there is really little within old externality because this is a smallish group and a very careful group. So they're only making 16% of the population. And when I say old here, I mean 65 plus. That's sort of where we chose the cutoff. It's kind of only a small fraction of the population. In terms of interaction in the steady state, they're only constituting 7% because they are very careful. And in terms of peak, when I say peak, I mean peak of the epidemic, it's only 1.5% of the interaction. So sort of locking them up beyond that is costly in terms of welfare, even though it saves lives. So that's kind of negative results. A lot of things don't quite work. So what would work? So what we find in the model is that separating activities by age, so preserving specific, for example, supermarket times for the old, that can cut deaths by another 10%. Testing by itself without any further quarantines also cuts deaths by another 10%. And then if we really have a serious test and quarantine policy, depending on how many people we test, depending on how perfectly the quarantining works, that can really cut deaths by 30 up to even 100%. We can, if it's going to be a lot of tests, obviously, and perfect quarantining, but then we can completely eradicate the disease. And for that, it's actually enough to test the young. The old, it doesn't really add anything in what we find here quantitatively. Okay, so let me start, because we're emphasizing, as I said, what I think economists can add is sort of this behavioral change, the voluntary behavioral change. And what I wanted to show here, this is data collected by Michèle below and others and co-authors. Well, Nick, you're part of this. So sorry. So my understanding from your research here is that sort of the voluntary social distancing by the old is a lot larger than by the young. And what I'm plotting here, I don't think it's in your paper, but from your data is what we plotted here is for normalized and normal times to 1, how much reduction in sort of outside leisure was there for the old and the young are the blue squares here. So that goes down by quite a bit at the beginning of the outbreak. And then even more sort of now, although when I say now, this is really end of April, I believe. And then the old, though, they have a larger response, and that's going to be key for us. For them, it's just more risky, and they will, in our model, protect themselves more. And that's what we see here in this particular data. The black circles here are the old, and they reduce behavior by more than the young. Okay. Now, there is by now huge literature on these topics, so I cannot give full justice to all of it. So let me just very briefly say that, in the theory papers that add older theory papers, pre-pandemic papers, adding equilibrium behavior, so adding sort of economics to epidemiology, usually what's being found, there's too much risk taking. People just don't take this externality into account. And it's been shown in the context of HIV, for example. Then in terms of calibrated, meaning really sort of calibrated to the data, prior to the pandemic, this pandemic, there hasn't been all that much. We have the sequence of papers on HIV specifically. And then again, Nick has a paper on this as well. But beyond that, I don't think there's really much quantitative economics work on this. Now, of course, in terms of new COVID papers, there's tons of stuff by epidemiologists, by economists, lots of people. I cannot talk about all of it. But there's not much work on testing, some, but not that much. There's a lot on behavior change, but then typically not with age heterogeneity. And then there's some on age heterogeneity, like the paper that Ivan Werning presented in the series, but there wasn't anything on behavior as in sort of the difference between voluntary reductions and optimal policy. It was all just comparing what's the optimal policy. We're kind of doing this intermediate step, filling in sort of what people do by themselves, and then how much can policy add on top of that. Okay, so then I'm going to jump straight to the model. I'll have, I know this is an interdisciplinary seminar, so hopefully I'll try to explain things well. There's some notation, but not too many equations. So it's going to be discrete time model with different ages, as I said, the young and the old. There is a health status J. And basically, people can be in one of 5 different stages. Either they're completely healthy, or they have, we call it a fever. But basically, these are the people who are unsure. They have some kind of symptoms, but they're unsure whether it's COVID-19 or just a common cold or flu or something like that. Then there's the infected. So when I say infected, really, I mean the ones who know they're infected. So some of the fever agents are also infected. So then they're the infected, and what can happen to them? They can either recover, or they can develop serious symptoms with some probability. And that's going to be age specific. And then once people have serious symptoms, so we're thinking about those being in a hospital, essentially, they can either recover or they die. Once they're recovered, we're assuming they're immune forever. I know this is up for debate. I think there's some partial immunity everyone believes now, or some temporary immunity is very likely. And I think that's all we need really for the model. But yeah, so that is an assumption here. There is testing in the model. So some probability of those who have a fever will be tested. Some fraction of those. Or, we can even do all of them, but then it's going to be a lot of people. Although, still some fraction only of the population, clearly. And fever by itself will also be endogenous here, because the more, think about the cold or even a regular flu, clearly that's also spread through interactions. So, the ratio will be endogenous, you'll see. Then there is a death probability. Well, once you have serious symptoms, I said you might die. And whether what's the chance you die in that stage depends on your age, but also on the availability of hospital beds. So just to see if there's sort of the ICU constraint or the ventilators it seems that makes a difference. So I'm going to show you now the version of the model without the hospital bed constraints. But we have robustness check. It doesn't make a huge difference. Qualitatively, it's very similar. Just quantitatively, obviously, it does make a difference. Yeah. Okay, so what do households do? Well, they either work, that's N, they spend leisure time outside, that's L, or leisure at home, D, for domestic leisure time. So think about either you can read a book, you're not interacting, or watch TV, you're not interacting at all with people, or maybe you want to go to the theater, or go to a restaurant, that's leisure outside time. So the teleworking I don't have today in today's version, so forget about that. The leisure, then there's goods that people get utility from, and that's the leisure goods, but also regular consumption goods. The leisure goods, kind of made up out of that external time plus some external goods, which is the X. So just think about if you want to go to a theater, you need to buy the theater tickets, plus you need to spend some time in the theater, right? Same for restaurants, same for going kite surfing or something else. So here are the preferences. So people derive utility from either, consuming, that's the C, that's regular consumption, and then consuming this leisure goods, the G. And then they derive utility from this, the D, that's the reading, think about reading or just hanging out at home. And then B is just a parameter, sort of how much people value just being alive on top of this instantaneous utility. And that's going to be a key parameter because that also affects to what extent people are voluntarily cutting back going outside. The more they value being alive, the more they're going to cut back. And then this lambda here, the first lambda, that's kind of bringing in some partial altruism. So basically what we're modeling here is if people are infected, they will if they know they're infected, they're going to reduce voluntarily somewhat their time outside just because they don't want to infect others. So they're not scared about themselves. They already know they have it, but at the same time, and I know this is different from what some other people are assuming, but my understanding from the H1N1 epidemic, for example, there are a lot of people who just cut back going to work, for example, just to protect others. So it's not going to be perfect, but some partial altruism here. And then the lambda P, that's sort of just a technical trick, how we're going to implement policies. So if we're having additional lockdowns, how are we going to make people stay at home more? We're just increasing this parameter. But then when I talk about welfare, I'm not using it to evaluate their welfare. I'm just using it to make them change their behavior. Okay. And that's pretty much it. Oh yeah, well, I should talk about the wages. So the earnings, clearly it matters for the young how much time they spend working. So that's the cost for them. They can socially distance, spend less time outside, but also means less time working outside. And that's going to be quite costly because it reduces their earnings. For the old, that's different. We're assuming they all get some constant retirement income. It doesn't matter if they don't work by assumption. And then there's a very simple budget constraint here. So then I said, even the cold is endogenous to basically proportionate to how much time people are spending outside, or individuals, right? So the N is your work time outside, and the L is your leisure time outside, and all of that together with some, you know, parameter affects what's the chance of catching the cold. For COVID-19, it's the same, except, you know, it depends on the aggregate prevalence rate. What fraction of other people are infected, right? If no one is infected, obviously I'm not going to catch it. So the, you know, so yeah, so it's going to be endogenous. People will sort of estimate over the course of the pandemic, whenever they have the fever, is it going to be a cold or is it going to be COVID, and with what probability is it going to change over time. Yeah, let me maybe skip these additional details here, but this is sort of tells us what's the probability of infecting yourself. So in some sense, like an aggregate prevalence rate, not just how many people are having COVID-19, but also how much they're running around, right? So that affects what's the chance I'm going to run into someone. Okay. So let me now talk about the decision making before I move on to results. And here I skipped all the equations, obviously in the paper for the economists who want to see all the value functions, I have all that, but I put the decision making here only in words. So, but there's lots of different types of agents. So depending on the infection status, people choose different things. So that's why I'm going to have a bunch of slides on decision making. So what do healthy people? So for sure, healthy people, what do they do? Well, they choose their time at work, their time at home, and their leisure outside. And they choose their consumption and leisure goods. And they choose all this to maximize their lifetime discounted utility, taking into account the chances of catching COVID-19 and the chances of possibly dying, but also their own time constraint and obviously their budget constraints. Now, for the people who have a fever, they choose the same things, but when maximizing their utility, they have to take more things into account. They take into account that they may already be infected with COVID-19 and how likely this is an endogenous object. So they have, this is going to be perfectly rational expectation. People know at any point in time sort of what's the true infection rate in the country. So that's an assumption, obviously. They also take into account if they, you know, if they don't have COVID-19, that they may not have it. Well, sorry, they may not have it and then they're worried about catching it, or they may have it and then they're somewhat, you know, willing to protect others. And then there's, again, the time constraint and budget constraints. And then I should say, when we add testing, we assume people basically immediately test it as soon as they get a fever, and then they know immediately whether they have COVID-19 or not. So in some sense, we don't have these completely asymptomatic infections. We assume you have some kind of a feeling that you might have it. And those people then, you know, if we're talking about testing, those would be the people tested. Maybe you can also think about this as a shortcut for test and, you know, tracing and testing. Yes. Okay, so what about those known to be infected? So once you're either tested or it's revealed, so if you have a fever and you're not tested, we still assume after one period, you know for sure whether it was just a fever or whether it was really COVID-19. So once you know you were infected, you still choose time at work, time at home, leisure outside, consumption and leisure goods, the same things. Yeah, you may, again, still somewhat want to protect others, but you're also worried about, you know, earning a living. So you're not willing to cut back completely. And no one here is going to completely self-quarantine themselves, but you know, some. And you may become critically ill, obviously, and yeah, the rest is the same. Now, finally, what about those that are critically ill or severely sick? I'm using that as synonyms here. Well, they don't choose anything. They don't work. They're literally in the hospital, and they may die or recover, but they can still infect others. So we're assuming basically sometime in the ICU, they are interacting with doctors, and even though the doctor and nurses, they're protecting themselves, so the contagion probability is lower per unit of time, but you know, it's not zero. And I think that's pretty realistic. A lot of contagion, I think, was or is in hospitals. And then we're assuming those recovered, they are immune forever. Again, I said that before, it's a strong assumption, but also I don't know if it matters all that much actually, but we can debate. Okay. So before coming to the results, let me briefly summarize how now age matters in the model. So age, is a key feature. I think the novelty, I think what at least what we find interesting in our paper is, well, the old do not work by assumption, so they naturally spend more time at home. So already just naturally, even without any behavioral adjustments, they are more careful just because they have less activities, they don't work. But also COVID-19 is a lot more risky for them. So the higher probability of becoming critically ill, and also once you're critically ill, higher chance of dying. And that makes them further increase time at home voluntarily. They also have a higher chance of dying from natural causes just because they're older, they're closer to sort of end of life. And that actually works in the other direction, but I think is a small effect. So then, of course, we're interested as macroeconomists, we're interested in aggregates. So what is output? It's just the sum of wages. The laws of motion of the disease, I mean, that is standard. That's, I think, how my understanding is how epidemiologists also model it. The death probability once you're critically ill is constant, unless if there are no hospital beds, then we assume you die immediately. But again, that's a robustness check, so I'm not going to talk about the hospital beds here right now in the quantitative results. Equilibrium is rational expectations. Yeah, let me skip that actually. Well, then we have to calibrate the model. We spent a lot of time and thought and energy in trying to kind of pick reasonable parameters. In the interest of time, I'm just gonna summarize this very briefly. Obviously, there's a lot of uncertainty about the pandemic, and and what we do in the paper is have lots of robustness checks on many of these dimensions. But basically, we're trying to calibrate to the US economy. I think different countries, we would pick slightly different numbers. The model period is a week here. The R0 is 2.5. I think that's sort of in the middle of all these ranges in the literature. The transition probabilities we're just taking directly from the CDC. With some adjustment, basically we're cutting the number in half just to kind of account for all the undetected cases. But this is clearly, we also tried, actually we have a robustness check with the Ferguson numbers, but in the end they're not that different in terms of total death. And the assumption is there's about 3 common colds or flus per year. So that gives us sort of the relative probabilities of catching COVID-19 versus the flus. The leisure outside, we're using time use data to calibrate that. And then this is important, sort of this bliss of living. So to understand how much people are voluntarily cutting back time, we're using Google mobility data from Sweden, because it seems Sweden was, a country that didn't close schools, didn't have all these bans, yet people, voluntarily, they didn't close the restaurants and the shops, and still people voluntarily reduced mobility a lot. And so we're kind of using that information on that to calibrate here our parameters. Okay, so in the last, I guess, 11 minutes here, I'm gonna now talk about the results. Well, to start with, a few non-targeted moments that people talk a lot about. One, I think, is the infection fatality rate here, and it's going to be 0.35, so only 1/3% of those infected die eventually. In the new version, actually, we're going to now double this, just because we're changing the parameters. So I think it is a little bit of the lower end in terms of ranges in the data, but I think my understanding is in the data is also typically is the case fatality rate, which is not exactly the same as the infection fatality rate, just because we don't know really how many people are infected, truly infected, all of these missed cases. So, but this is clearly, a lot of kind of some uncertainty about these parameters. Another thing that's maybe interesting is that in our model, in the long run at least, the ratio of death of old versus young is only 34% of all the deaths are accounted for by the old. In the data, it seems much higher, about 80%. But let me point out that endogenously changes in our model. So look at the table at the bottom here. That endogenously changes in our model over the course of the pandemic. Initially, a lot of old people die, and then only in the very long run here being a 1.5 or 2 years or so, the ratio endogenously actually changes. Okay, so here are the benchmark results. So Yeah, okay. So I'm going to show you a bunch of such tables. So let me briefly explain what I mean. So there's a bunch of different variables, outputs I want to compare here in terms of, you know, what fraction of people are seriously ill, how many are dead in the long run, but also how many are dead in a year, what's GDP decline, and so forth. And what I'm showing you here is what's the benchmark versus at least what we call an epidemiological version of the model, meaning we're really holding just behavior constant. So there's no voluntary social distancing. And I think the important result here to point out is that just without any government policies, here already just through voluntary social distancing, people are, you know, basically reducing deaths by 50%. Here, look at this orange line and sort of in the middle, I don't know if you can see my mouse moving. So rather than four out of 1,000 being dead in the long run, it's going to be only 2 out of 1,000. Or for the old is even much more substantial. Rather than 15 out of 1,000, which, you know, would be quite substantial, it's going to be only 4 and 4.3. So that's sort of what happens in the benchmark. Now, the question we want to ask is, well, yeah, in GDP, I should say, voluntarily will also decline some. You know, here it's only by essentially 3 percentage points. So that's something maybe we can compare to actual data, again, maybe from Sweden, to see if their GDP decline is actually lower than some other countries, potentially. Here's just some plots, but just to illustrate, but in the interest of time, let me kind of skip this. I think we've all seen lots of plots of this type now, but basically here I was comparing, again, our benchmark versus the epidemiological version. And I guess what you see here, if you look at this graph on the middle left kind of panel here, the MFI, that's sort of the pandemic being, you know, you see the flattening really. So just through the voluntary social distancing, there's a lot of flattening. But I know, yeah. So next thing I want to point out before moving to the policies is about these externalities specifically. So think about the young are more risky than the old, because for them it's just not as dangerous. And that could mean that sort of they're too risky. And so what would happen if we just gave them the beliefs of the old? That's what we tried here. Then would it help? Sort of if we just told them it's super risky for you too, what would they do and what would happen to death? And this is the partial equilibrium version. This shows if they really change their behavior and nothing else changed, it would cut death. However, in general equilibrium, so taking into account, so everyone adjusting their behavior and really running through the end of the pandemic, in the long run, we're actually going to have more death. And the intuition here is it increases from 2 to 2.4 per 1,000. And especially for the old, it increases quite a bit. And the intuition is, I think in some sense, very simple. It's much more risky for the old. So if the only solution is sort of getting to herd immunity in the long run, it's better to reach that through the young than through the old. And if we just kind of, if we let the young behave as they want, we're gonna get there actually mostly to the young, and that's good for the old people. And then we have fewer deaths. Okay, but now let me move on to the policy experiments. So, you know, we're gonna consider quite stylized policies. We'll talk about shelter at home, selective mixing by age, testing and quarantining. And for all of these, we're also considering age-specific policies. So just for the young, just for the old, or just for all of them, and different length and severity for the shelter at home policies. So let me be very clear what's our metric of success of a policy? We're always comparing it to the benchmark with voluntary reductions in time outside. And so we can basically have policies that are good and compares to what we call a epidemiological benchmark, but don't add anything above the voluntary reductions. So let me be very clear. That's sort of what we call a success of a policy. We want to know, does the mandated lockdown sort of add anything beyond the voluntary lockdowns? And then in terms of outcomes, we're considering, in some sense, death over a year, just sort of with the understanding maybe after a year we have the magic cure, but also death in the long run, assuming no cure happens. Then we're interested in GDP. we're interested in sort of the cost per life saved, and of course in welfare. So, and we can look at the welfare of the young or the old or all. And when I mean welfare, it's just literally using their own utility functions. So the whole discounted lifetime stream of utilities. Yeah, so the choice of the benchmark for the comparison is important because, as I said, some lockdown policies are welfare improving, but not so if we really compare them to this benchmark. Okay, so shelter at home. If we do, so for those who want to really look at the paper later on, we're doing, this is just something on notation. We're going to have mild policies. So this 25, for example, means 25% of the time we're increasing your time stuck in the house by 25%. We're doing it for everyone, and we're doing it for 4 weeks. And then we can do all kinds of combination, more weeks, or just the young or the old, or more time, and so forth. So the thing I want you to focus on here is, again, the dead in the long run row, that basically in some of these light policies, either there is no effect on death, or in fact, it may actually go up. And that's through the same effect I was describing before. We're basically getting to herd immunity more, involving more old people. If we get it over with faster by locking up the young less, then we can actually get there faster and in some sense save more old people, at least in this model. Again, this is with many assumptions, so I'm happy to debate. In terms of, even for the old, actually I should say that the deaths here go up by quite a bit in some of these policies. Now what if we did a stricter policy and we did it for longer? So then, in the short run, it can work in the sense, so look at the number of deaths over the first year. So, actually even though the policy is only for half a year, actually it kind of works for a while. Even after the lockdown is over, it slows down the pandemic quite a bit. So again, if the goal is to save many lives within the first year, then this is a good policy. If after 1 year no magic cure happens, and we're talking about death in the long run, then really we're not saving much here. It's pretty much nothing. So and this comes at a huge cost. So GDP here goes down by a lot, actually. Over the whole year, 40%, more than 40%. So this would be like a policy that has basically no benefit and huge costs. So that shows up in the welfare numbers. No one likes it here, this policy. So the welfare here compared to the benchmark goes down. Well, why is it? I think it's kind of obvious. The whole policy only shifts the peak. So here the solid lines are with the policy, the dashed lines is the no policy. And it works, but it works only for a while, and then eventually the same thing starts over. Now again, if by then we know a lot more, or we have a cure or something, then it's a different matter here. Okay. So suppose we shelter only the old. I think there's a lot of, and I'm running out of time here, I realize. So if we just shelter the old, that actually can cut deaths quite a bit here. But even then, the old don't like it. And why is that? I said that before. I think they're already sheltering themselves a lot and doing more so. And there's not much of an externality because they're a small group. Okay, so I don't have much time, so let me kind of say a little bit though about what works, right? If the lockdown doesn't work, what else could be done? So, preserving specific spaces for the old, so selective mixing, we consider that, testing and quarantining. And we do find these policies work to some extent. So here is the selective mixing, where we separate half of the activities. We're assuming fully separating is not possible. You need a nurse to look after a 100-year-old person, for example. But still, that would cut death by 10%. Testing all by itself without quarantining actually cuts death also by 10% here. And this is because of that altruism. People will be, somewhat cautious and not spreading it too much when they're tested voluntarily. Now, if we test and quarantine, then we really have the potential to completely eliminate the disease. I think maybe that's a strategy of South Korea. I think Germany is headed there too. And, or I think Australia, maybe, and New Zealand are close. So maybe, that's a good policy. And in fact, can even lead to increases in GDP relative to the benchmark here. So here we have a 24% increase in GDP. Okay, in the interest of time, let me skip that. Obviously, there's a lot of robustness checks we're doing, hospital bed constraints, a lot of caveats still, you know, and things we're working on right now. So what if a vaccine happens? If we're counting on that, actually results are quite similar. We just solved that version. It's not that different. And teleworking is something one can think about. Yeah. Last, because if you're thinking really, if a policymaker is listening, since it was a negative result that lockdowns don't make sense, I would spend a lot of time brainstorming when could they make sense, because it seems like maybe they cannot be so bad. So of course, if they're in place until the vaccine is widely available, maybe they make sense. Of course, it buys time in general to learn about what else works, like masks, the meat factory issue, other cures or, medicine and so forth. And also, if people have the wrong beliefs about the mortality rate, so if people are just not cautious enough because in some sense they don't take the disease seriously enough. So these are things we're working on formalizing. Okay, conclusion. Large voluntary behavioral adjustments, that by itself reduces the death rate by 50%. The mandatory lockdowns do not work so well. They may, in fact, backfire and lead to more death. Even when they reduce death, they may lower welfare, but they do buy time. What works, at least what we found in our model, is the preserving spaces for the old. And I think some countries are doing that now, especially for the supermarkets. That works some. Testing by itself works. Testing and quarantining, of course, works really well if you do it on enough people. And yeah, that's it. So thank you very much. And then I guess I'm handing over to Melissa for the discussion. Looking forward to that.
I'll just say that if anybody has questions, to go ahead and use the chat function or the Q&A function. But I'm happy to monopolize questions. I have plenty. So Melissa, are you good to go?
Okay. Can you see my screen okay? Okay. So thank you for that really great presentation. I really like the way you presented the impacts of your model in your discussion. And it helped clarify some things that I read actually in the paper. I want to start my presentation by saying that I am actually an applied epidemiologist and not a modeler. So my comments and my questions will really represent myself, but also the health department folks that would be the target of these sort of results, and the people that would need to use the results to think about policy changes. So my presentation is geared that way, as opposed to a critique of the way the model came together. Or questions about how the model came together. Although as an epidemiologist, I am posing questions about some of the parameters you used. So I want to start because since epidemiologists think slightly differently than economists, with just describing when I read this paper, that was very complex and long, and very, very great paper, but complex and long, what I heard happening in it. And the objective of the modeling appeared to be to predict the speed and impact of COVID on health and survival and the economy of the US, or of the economy of a location. And the key methods I saw were fitting the model based on epidemiologic, demographic, and economic parameters, most notably using old and young people, and talking about differential death rates for those groups. And it was calibrated to be consistent with known data. And then some of the key outcomes I saw were a baseline scenario. I looked at a test and quarantine scenario, a shelter-in-place policy, and I think there was one other scenario that was posed, but it wasn't complete in the version I read. So, and then the scenario I think was tweaked for various assumptions, and I won't go into that much more. So I guess the first thing I should say is I hope I got some of that right. And what I saw as far as parameters, you heard about just now, but I keyed in on some epidemiologic parameters, including age and differential mortality, COVID-19, and fever status, infectiousness of the cold, presumably the flu, if it's represented by a fever, immunity, recovery status, hours inside and outside the house, and then economic parameters that I have to be honest, I did not pay as much attention to because of my area of expertise, but consumption, paid wages, and value were some of those that I indicated. So I'm going to jump right into a few questions about the model, because just based on my work with the City Health Department in prior outbreaks, these are the things that we have thought about being important. In COVID, age is very important, but there are specific comorbidities that are also associated with poor outcomes. And have you considered that in your model, or considered adding it to your model? Crowding and housing conditions that lead to more transmission is important in COVID. As far as exposures, when people are outside of the house, you probably have a differential exposure for people who have essential jobs that force them to be in contact with other people versus people who telework. I was wondering if there was a way to take into account elevated risk of transmission or death among older adults in congregate settings, because we found that to be a very important group that has had lots of severe outcomes in the US and I'm sure other places. Also, I think we talk a lot about transmission in this model, if I understood it correctly, as far as you are susceptible to getting the disease or being exposed to the disease when you go outside of the house. But we also know that I think those of us working with US city health departments feel like the most important group who's susceptible to getting infected, obviously after someone has gotten infected outside of the house, are people in the household. So thinking about how you could take into account household transmission if you haven't already in the model. And then finally, I think there's a discussion about quarantining of cases in our epi kind of parlance. We usually call that isolation. I was wondering also about quarantine of contacts, which we as epidemiologists feel like is a really important part, and you alluded to it as well in your discussion just now and in a couple statements in the paper. Have you considered trying to take that into account in the model? Some other questions from an epidemiologist perspective, the first of two. You didn't go into this particular finding so much in your discussion, but I thought it was a really important finding, and I'm sure if you'd had more time you would have. You did mention that the quarantine after testing was one of the most important factors in reducing the impact of the epidemic. And I agree with you, and using this 50T version of this model, which suggests that only people aren't tested and immediately isolated, they're tested and it takes time for their results to come back. And then I think that's a smart way to think about it a little bit more practically speaking. There are other lag times around between infectiousness and getting isolated that should be taken into account, both on the testing side and on the isolation and quarantine side, that I would ask you, or I guess suggest to consider in another model. my second of the two slides, I wondered, I alluded to this a second ago, was it intentional to suggest that transmission occurs when outside the house? I may have missed this in the model, but it seemed like that would miss household transmission. And then are there other ways that you're also, are there ways that you're taking into account asymptomatic and pre-symptomatic spread? Because that is such a unique factor in this pandemic. We haven't seen, or at least understood, that there's that much pre-symptomatic and asymptomatic spread in many of our other outbreaks that we've dealt with. And then you mentioned this in your discussion, that you used immunity and resistance in the model as if once you get the infection, you're always immune. And I feel like that it would be good to tweak that based on both some indications we've seen in the literature and emerging literature. And then the other thing I wondered about is, I thought I understood in the model that it suggested that someone can fail to recover, but stay infected for 3 years. So I'm sorry if I misunderstood that, but if you could tell me about this assumption or fix my misunderstanding. So finally, I'm going to give you like 2 or 3 slides here to describe sort of my impressions of reading the paper. So this is a very, very highly scientific graph that indicates the usefulness, with 5 as being the highest, versus the length of a paper in number of pages. And I say this in jest, but I'm also trying to make a point here that for these kinds of modeling exercises to be useful, we do need to have people like me and people that I am working with at the health departments understand what you're saying and be able to incorporate it into their practice. So this is one of the key tables that was in your paper, which is full of a lot of really important findings, including the one I pointed out with the Q90A50T. But it's too much for somebody like me, and it's really hard to interpret, and there's a lot of jargon in it. And so these tables, which I don't know if the top is covered up by your photos, but like it is on my computer, but they, you can get a feel for what they say, but the way they're presented here, you have to do a bit of work to figure out what they mean, and just a little bit of a presentation that would give titles and describe what the letters mean and what and labeling could help with this. So this is going to be sacrilege, because I know that you're going to say that we're not holding up a specific model as a gold standard, and I'm not doing that when I show this IHME model here, even if the underlying model is garbage. It's understandable in 1 minute based on this presentation. You can pull it out from the web. So wondering if a bit more on the simplicity side could be useful. And then there are 2 other instances, and I actually think I have to. I'm gonna show. Let me. There's one of them that is a map, and I actually have to. I have to unshare. Sorry, 1 second. I'm gonna share my desktop instead. And this is an application that has recently been developed by a group in the ID Dynamics group at Johns Hopkins School of Public Health, particularly Emily Gurley and Justin Lessler. And it has, crunching my numbers, it has an interactive dashboard where you can show, what you get when you input things. And then it can even allow someone who's more sophisticated to go through assumptions. This is a good way to present data to people like me. And let me see if I can also pull up this one. Oh, excuse me. One other place, and then I know we need to go. This is a something from the CDC's website. It's about flu, but a changing map, like a movie is also a nice way to show change over time. And I know that your data may not be geographically specific, but we do know that this epidemic is both, it's really dynamic and local, and thinking about ways to present data that let us epidemiologists understand it, and also to convey it to policymakers is, I guess, the suggestion I'm leaving you with. And the last point I'll make is that even really excellent science isn't going to be used or seen unless it's presented in a way that epidemiologists can understand and move with it. So I'll stop there. Thank you for the opportunity to review this paper.
Since we don't have a lot, so thank you very much to both of you. This is really fantastic. So a couple of things. I'm happy to stay past 1 o'clock for more discussion. Michèle, in the last few minutes, maybe you want to respond. I'll just tell you that from the questions that we've gotten, there seem to be like kind of two big themes. One is, why isn't there more, this is my question as well, like why isn't there more heterogeneity in the model, not just young and old, but racial differences, the housing arrangement differences and such. And is it possible, understanding of course fully that it's hard to get these models to come together. And then the other one is this, I think what Melissa was pushing on, this idea of how to translate this kind of research. So it's useful for people, on the ground. And then we had one last question that was asking you to expand on this notion of kind of achieving herd immunity by young people kind of hanging out together, how realistic that is. I also had that question because, we're currently running that experiment in a few states, it seems like. So if you want to just pick any one of those, and then people can sort of leave when they need to, and we can continue.
Okay, well, let me first thank Melissa for an excellent discussion. And I'd love to get those slides later. Lots of really great points and questions. So let me try, and two of them overlap, I think, with what Nick said. So let me start with answering those. So I think there were a lot of questions on heterogeneity. So, I mean, obviously, yeah, depending on how people live, the housing conditions, comorbidities, even the occupations, obviously, I think it's pretty clear there is heterogeneity, and a lot of heterogeneity, or the nursing homes, a lot of heterogeneity we're not modeling here. So I don't want to say they're not important, but at the same time, I think to learn something and generate insights, we need to abstract and be sort of, zoom in on something specific. I think just think about a map. I mean, a map, if I'm trying to, find my way from here to Italy, I'm not going to use a map with all the little tiny streets in between. I'm not going to make it to Italy that way. So I think that's sort of the analogy I want to use, that, depending on the question, I think it is important, or is useful, is really the only way to abstract from some heterogeneities. And that's not to say that we shouldn't then, move on and build upon it. It depends on the specific questions too. If we're talking about how important are school closures right now, or not closing schools to prevent the epidemic, then, better we add young people to the model, and having this household transmission that Melissa was talking about, that, the kids infecting the old. Or if we're interested in young people really infecting the old within households, like maybe in Italy, I think that was a big issue again, because it's just more intergenerational households, then we do want to add that. So I think it really depends on the question, but we cannot always put everything into a given model is my answer. I think this also speaks to a second question, but also, I'd encourage everyone to maybe build upon it, add these things. Eventually we're going to make, or soon hopefully, we're going to make our code available. So maybe other people can, other economists maybe can use that to add some features and see how important is that. And then a second question, both I think by Melissa again and by Nick, is sort of in some sense is, so even though you want me to add more heterogeneity, it's also too complex. So it's a little bit hard to do both, but I mean, I see the points. But as Melissa was saying, to really have policy influence, the paper better be short. So, 5 pages or so, it's really hard to add all this complexity and be short. But let me say that we also wrote, probably the economists should know this, a Vox EU piece. The epidemiologists probably don't, but it's actually a lot of the econ COVID research is written up in sort of 1,500 word summaries, accessible to a broad audience, written for policymakers, for journalists, for other disciplines, and so forth. It's really, and so we have this sort of 4-page version of our paper that kind of much more succinct. I should have sent that to you actually, sorry. So I think that's sort of the way I see this to influence policy, to have sort of both versions, I guess. The long one for everyone who wants to build upon the research, knowing all the details, and then the short one for the policymakers, maybe. Can
I just interrupt you for 1 second? I just wanted to say it's 1 o'clock, so for those of you who have to leave, thank you for being here. Thank you to Michèle, thank you to Melissa. For those of you who want to continue the conversation, I'm here until to shut the lights down. So thank you very much for attending, for your questions, and hope to see you next time. But I would just say carry on and see if we have any more questions as well.
Okay, so let me say a few more things to Melissa's. Again, great discussion, great point. So I like your moving maps and the dashboard examples and all that. I have to say, I personally have no expertise in sort of developing something like that, but it's maybe, I don't know, maybe something we should. Maybe I need to hire a postdoc to, or a PhD student to make something like that. I personally have never done this, but I think it's a good point. There was also a point, I think, on geography per se being important, and I agree with that. It seems a lot of the outbreaks are, we just had this 1,500 people infected in a meat factory in Germany. So a lot of people in one place, but it's very geographically. So yeah, we probably should also build more models really with geography in it. But again, I think we cannot do everything at once. So yeah, then 2 more points where actually I have questions for you. So the immunity assumption. So we're assuming it's perfect immunity after you recovered. I would love to know what the sort of what the literature by now thinks, what sort of the truth is. So if you can point me later to some good, I don't know, references, papers, because my understanding is this is really not known, I guess. And sort of similarly, the asymptomatic spread. I understand we don't have it in a model. We have the fever spread in the sense people don't know, but they have some kind of symptoms. So to what extent is there people who have nothing, not even, something like a cold? And I don't know if you can point me to some reference, some literature on that. I'd love to see them. And maybe, and then the last point, you said something about the people being infected for 3 years. I think that must have been a misunderstanding. I mean, yeah, I think that's it. So thank you. I don't know, Nick, if I answered your questions as well enough.
No, I did. I think you did, and I think so this is maybe it's less of a critique or a question, but I'm thinking about what would be the next important questions. So I think the first order kind of important question is this heterogeneity by age, not only in the choices that you make, but then in these kinds of transition probabilities, how things are going to evolve. The one that and this is probably because I live in Baltimore, and so if I go 2 blocks to the east, you're going to see a very different set of behaviors, much more crowding. In low-income communities, I think there's some research emerging saying that young Latin American people, some people who are, of questionable immigration status, don't have the ability to sort of stay at home. Like they're going to work. I have doctor friends who are saying that they're coming to them and saying that they had a fever and they went to work. And so this is just extremely different from what I would have done, and not, because I'm a nicer person, but because I am able to sort of telework. I'm guessing some of that heterogeneity would come in through your altruism parameter, and also through this kind of consumption utility, because it would be different, I'm guessing, for different groups. And so that for me is the next thing to do. I'm just curious what your thoughts would be on that. And we can do some of this offline, but since we're here.
No, so clearly we assume a sort of a representative young agent, and that's capturing a lot of different people in some sense. And what we call only partial altruism is not meant to sort of say people are egoistic, but partly it's also some people, as you pointed out, don't have sick leave policies, for example. It's very costly, people are not gonna not work and then starve to death and not being, or not to death maybe, but not being able to feed their kids or pay the mortgage. And so we're kind of trying to capture those things in one very, I guess, ad hoc, or not ad hoc, but stylized way. So clearly there's a lot of heterogeneity behind that. I totally agree. And the crowding, yeah, I mean, different people. Yeah, if you have a big house and you have, room for every kid, and you have a garden, and you can work from home, obviously the ability to telework is key. So we spend a lot of time, we kind of build that into the model, but then in the end we didn't use it, because it's just exploding. Already we have 60, 70 pages in the paper. So at some point we said, we've got to stop. Not because we don't think it's important, but it's otherwise impossible to digest for anyone, I think. But maybe that's one of the important steps. I mean, there's a lot of already evidence that, the more educated they can telework, and sort of poorer people just have jobs where you can't. And so that obviously makes a big difference. I think it's clear. Yeah.
So Nick, if I may jump in and shamelessly advertise something else, a subset of co-authors, Luis Brotherhood and I, were taking this model because you said about crowding, and I guess that's particularly an issue in developing countries with slums and things like that. So we are adapting this model to Brazil, to Rio de Janeiro in particular, in which there are 20% of the population lives in slums, and then the difference in crowding in the different sectors matters a lot. And some people are richer than others. They have to go out and work and not. So it's a different type of heterogeneity, which, going back to Melissa's point, we're doing other heterogeneity there, but in different papers.
That's great. We should chat. You might be doing what I was thinking, what I've been starting to do already, so then I don't have to do it. But it'd be fun to talk.
I can't tell. It's in the oven, but nothing done yet. But yeah, we can talk.
That'd be great.
There's also an interesting related paper by Titan Along and David Lagarkos and others, also for developing countries, and they make the interesting distinction between people working in the formal and informal sectors. And then basically, if you're just locking down the formal sector, you might have more people in the informal sector and crowding more there, and that could backfire too. And sort of that's what they investigate. Again, more applied to developing countries.
I have one comment here that I'm trying to understand. Does the model by Emily Justin point to different policy decisions? I don't know.
I just I think that's the one that I sent a link to the interface.
Okay.
And it's in soft launch, so they're going to kill me if I publicize it too far, because they're working out some bugs. But that model is not trying to do the same thing as this model. It is a contact tracing model. But I was showing it to show sort of a way to present something that is a bit easier for applied epidemiologists to use. But I've put a link in here. Just don't give them a hard time if there's still a few bugs.
Yeah. Okay. Thank you.
I just want to say one other thing about immunity. I agree with you, it's not settled, but I think people generally think that it is, and I think some papers are showing like 4 or 5 months, or it's still an emerging area of understanding, I think. And I mean, the pandemic hasn't been going on long enough to really look at this carefully, but I think, you know, based on other coronaviruses and based on the few small things that have come out, I think it's thinking about immunity as lifelong after one exposure. I'm not sure that I would make that. I wouldn't bet the farm on that at this point.
I wonder, I mean, it seems like it would be fairly straightforward for you to use the existing model with some tweaks just to explore implications if it's 6 months and just see if we get drastically different answers.
No, we could do that. Yeah.
Well, I think I'm gonna go ahead and end this. I really enjoyed this discussion, and it was just nice to see all of you. I'll probably be emailing some of you. I'm sure that we all have each other's emails. If anybody wants to email Michèle, you can go to her website and find out how. And we hope to see you at the next one. Is there anything else I should mention, Mario or Marcelo?
No, I don't think so. Thanks again. This was really great.
All right.
Well, thanks for having me, and thanks again to Melissa for a great discussion, really.
No, my pleasure. Thank you so much for inviting me.
All right. Thank you.
Bye.
Thanks. Bye.
Bye, guys.